Yeah, good afternoon, Professor Lin and all colleagues. This is Sunu from Indonesia. Nice to see you.
Great to see you. Great to see you. We are just about to start.
Yes. Are we going to start now?
Yes, I think it's time now. Okay, we can start now.
Okay.
Okay.
Hi, everyone. Welcome to APSC Cloud Forum of Cardiovascular Disease Series. Today we have program of paradigm shift in contemporary atrial fibrillation management in 2022. Next slide, please. Yes, we all know the atrial fibrillation is not only a simple arrhythmia, but also a risk marker of underlying cardiovascular disease and adverse cardiovascular events. So early detection and early rhythm control are becoming the two main foundations in the paradigm shift AF management. So in this symposium, we will think deep into the core question in the new therapy strategy, including the role of mobile smartphone for AF detection, the re-embracing of rhythm control strategy in AF management, and the prevailing of rhythm control strategy in half-breath or half-path, and the prevailing of reliable cryo-ablation of circumferential PV isolation in atrial fibrillation interventional therapy. And the final, the pitfall of left atrial appendage occluder for thromboembolic prevention in OAC refractory or OAC denial AF patients. So I am Dr. Mingxian Wen from Chang'e Memorial Hospital, Taoyuan, Taiwan, the chairperson of this forum. And my co-chairman is, next slide, Dr. Miyako Igarashi from University of Tsukuba, Ibaraki, Japan. So let's going to start this program. So before that, I will read the disclaimer. The content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. And regarding the housekeeping, the live streaming content of this webinar will be made available via APSC Cloud, APSC Facebook, and the YouTube page. Okay, so let's start today's program. Today we have invited 5 experts in Asian Pacific region to talk about above important issue. The first speaker is Dr. Francis Lim from Brunei Cardiac Center at the Raya Isteri Pengiram Anaka Salera Hospital. Dr. Lim will talk about the smartphone detection of atrial fibrillation could be a risk marker of adverse CV event, true or false. Let's welcome Dr. Lim. Dr. Lim, please.
Hello and good afternoon, everyone. Thank you very much. I'm Francis from Brunei, so just bear with me while I share my screen. Can you see my screen? Sorry.
Not yet. Not yet. Please try again. Okay.
Can you see my screen now?
Yes.
Yeah. Okay.
Okay. Okay. So today I have the been asked to talk about smartphone detection of AF as a risk marker of adverse cardiovascular events, true or false. So I think we all probably know what AF is. It's one of the most common heart arrhythmia when you have atrium is beating irregularly. Okay, and the current guidelines suggest that the gold standard of diagnosing AF is either 12-lead ECG or single-lead tracing. So this is just a 12-lead ECG of atrial fibrillation. So just briefly, not all AF is symptomatic. Up to 30% of patients have no symptoms, but we know it's a common problem. It's increasing as you get older, and patients with AF are increased risk of heart failure, stroke, cardiovascular mortality, and it has can affect patients in terms of functional status, affect their quality of life, and it's increasing burden of healthcare systems, and this is just Europe, but probably worldwide. And we know AF is one of the leading causes of strokes and hospitalizations, and of course, again, hospital visits. So once we have diagnosed AF, for example, we usually do what a Chatsworth score and a Hasbled score for bleeding and stroke risk. And so we assess patients' bleeding and stroke risk and start treatment, most commonly with antithrombotics such as warfarin or the NOACs. And in patients who may not be suitable, we may do other more invasive treatment. Of course, this is based on patients' preference, risk benefit ratio, and of local availability of treatment. Okay. So those are sort of patients we've diagnosed with atrial fibrillation. Usually, when they go to hospital or clinics when we see them. But what about the patients who are probably asymptomatic, or if we know up to 30% of patients are asymptomatic. So, people have been looked into. This is a paper in Circulation. So we can do opportunistic screening. So anyone who comes to hospital, usually older patients with risk factors, we check their heartbeat, feel their pulse, maybe listen to their heart sounds, and maybe do a ECG. Or we can do some systematic screening. So we invite everyone sort of higher risk, for example, age 65 in this example, and just check everyone. Or what I'll be focusing on is more the consumer-driven. So, so younger patients who have access to what commonly a lot of people now have smartphones, smart watches, where anyone can check their heart rate and even heart rhythm. And of course, we have continuous recordings, which are more invasive, perhaps with implantable cardiac monitors and patches, which we can monitor. So there is a trade-off between, increased intensity of the screening, which we can increase AF yield and stroke risk, versus shorter periods of checking, but slowly. We get lower AF yield and perhaps bigger stroke risk, but we also have to think of our the patient's risk and how intense we want to do the screening. So just focusing on the more consumer-driven monitoring, we have the ECG-based handheld devices. We have ECG or PPG photoplasmography-based smartwatches or bands, or smartphones, PPG-based. So this is one of the ECG-based monitors. So this is the Alive Core. So you need an external machine where you put your fingerprint, your fingers on it, and it connects to your smartphone, and you can get even up to a 6-lead ECG monitoring, but you have to buy the machine. And smartwatches, which some people use. But most commonly, I think a lot of people now have smartphones, which uses something called a PPG. So you use your light source and camera, and the machine will show your smartphones will show something like, and whether it feels your pulse is regular or irregular, for example. Okay, and then based on that, we can perhaps suggest the patient has atrial fibrillation, for example. And there have been papers looking at detecting AF with smartphones and smartwatches, and it has been shown that it can pick up irregular heart rhythm and atrial fibrillation. Okay, so it is potentially can be used for extended atrial fibrillation screening. But what about, in patients, these are in sort of, more of a opportunistic or suppose consumer-driven atrial fibrillation. So usually patients were asymptomatic. So this paper is just in patients who have a sort of cardiac implantable electronic devices. For example, without clinical AF, it's detected atrial fibrillation using the atrial lead. It suggests that they are associated with increased risk of stroke and systemic embolism. But these are, so what about patients or people, not so much patients, but in the public, we've detected sort of AF, subclinical AF who are asymptomatic. Is it useful? Is it effective and cost effective? So there have been some papers looking at mobile applications for detection and management of atrial fibrillation. So it's shown that this is potentially improving AF detection, but perhaps we have to think of improving app quality and functionality and how, accuracy of these smartphones and apps. Okay, and this is another paper published quite recently. What it has said is that there is a clear potential, but inadequate data to currently advise clinical practice on real value of PPG for AF because it's a highly selected population. There's quite a bit of heterogeneity, and how do we actually call what is AF and what do we do with it? Okay, because you still need to confirm that patient, the person who has atrial fibrillation. Okay. So again, some papers say it's not clear when a mobile health detected episode of AF must be deemed significant, whether it's a few seconds, few minutes. Okay, and then the paper said, so ultimately the association with patient important outcomes is uncertain, even if we detect AF, especially for the younger patients, who will be probably monitoring their heart rate and rhythm than the older people who are at risk, right? So they probably have CHADS VAS of 0, for example. So this is a paper published last year in Loop. So these are, when we talk about subclinical or silent AF. So this is a paper that they use implantable loop recorder. Patients who are high risk of AF and to detect if for silent AF, and if so, we treat them. So in this, just for the conclusion, the authors have said in the population of high-risk patients, atrial fibrillation was detected and treated much more than those undergoing ECG monitoring. And they found a non-significant 20% reduction in risk of stroke, but was not accompanied by a similar reduction in cardiovascular mortality. So they say that more studies are needed, but their findings suggest that not all AF is worth screening for, and not all screen detected AF merits anticoagulation. So, so it just suggests that we may have to start thinking more about what we do with these patients. But in the subgroup analysis, that patients who benefit more are patients with higher systolic blood pressure. Okay, so it suggests that perhaps it's not just the AF, but also risk factors for stroke and also risk factor for AF, such as hypertension, is something we need to perhaps think about more, and in intervening in a healthy lifestyle and treating, for example, risk factors such blood pressure where appropriate. So the other thing, this topic is atrial fibrillation. Is it a risk marker for adverse cardiovascular event? So when it comes to AF, we have to start perhaps thinking of how we approach it. So is it a risk factor or is it a risk marker? So if you think of it as a risk factor, we just with atrial fibrillation, with irregularity in the atrium, if we think of the Virchow's triad with hypercoagulability, stasis, endothelial dysfunction, and clot formation, whereas probably we need to think of AF as more as a risk cardiovascular risk marker. So things like hypertension, diabetes, sleep apnea, obesity, sedentary lifestyle, which are a marker for cardiovascular disease, and increases your risk of atrial fibrillation. So we should be thinking of AF less as a direct cause of a stroke, but as a risk marker, because it's not, there's not always a temporal risks in terms of AF and strokes. Okay. And this is a paper looking at physical activity and accelerometer, so using your smartwatches. So, and what it suggests that in patients who doesn't, with more vigorous and moderate to vigorous physical activity, they seem to have lower risk of AF and suggest that they are probably a more healthier lifestyle. So this is just, again, a risk marker, okay? So to answer the question, is smartphone detection of AF a risk marker of adverse cardiovascular events, true or false? Yes or no? Or maybe just a little bit. So, I mean, personally, I think it is. It suggests that this, when you detect atrial fibrillation, it suggests that patient is probably, a risk marker, but it doesn't mean we need to anticoagulate, but we probably have to think of addressing their cardiovascular risk factors and treat that, and that reduces their probably atrial fibrillation burden and risk of stroke as well. So I think that's the end of my talk. So I'll stop sharing now. Thank you very much.
Okay, thank you, Dr. Lim, for your nice talk about the smartphone screening of atrial fibrillation. So is there any question from the panel? Okay, may I ask some question?
Sure.
So how do you suggest which kind of a high-risk patient to have such a smartphone screening?
Yes,
and
I think
the second question is which kind of screening modality is better, such as ECG-based or PPG-based or camera-based?
Okay, thank you for your question. So for the first one, sort of a high risk, so it's population, I suppose it depends on your local availability, and then deciding which patients we should screen, because rather than screening everyone, we probably have to think of inviting, taking opportunistic screening for patients who are higher risk, perhaps if patients with diabetes, hypertension, sort of older patients, which we probably be thinking of anticoagulating them, for example. All right. But we have to think of how you manage once you detect AF. What do you do with them as well? And so you probably need to involve your GPs and other stakeholders for assessing that. And then in terms of which is the better one, I think probably if you ECG and smartphone, you'll have to buy one. So perhaps something like just a normal ECG smartphone, which a lot of people have access to, just with a PPG, I think, which I think uses your camera and light is probably the simplest, and which most people will be more familiar with.
Yes. So do you have any experience of your patient? They will show the smartphone or smartwatch detection of atrial fibrillation in your clinic. And so how do you suggest them the following treatment or suggestion, or how do they reduce their risk?
Okay, thank you. I personally have not come across anyone come to me with AF yet. They do come to me with other, arrhythmias and tachycardias. But so far, the ones that have not do not show the ECG, okay, or tracings, just the rate. So we'll probably have to think of some apps. I think that they probably will personally not that familiar yet. I think there are some apps, and probably Apple Watches have also this monitoring, ECG recording. again, we'll have to think of, locally how you manage that, patients, whether you come and do ECG, and if they detect some abnormality, whether you have to do prolonged monitoring, etc. So I suppose, again, I would say it all depends locally on how they want to approach it, really.
Yes. And do you suggest to use a screening program in your community, or is that your strategy in your country to screen the high-risk patient in your community healthcare system?
Okay, thank you. So at the moment, actually, we have tried screen. A few years ago, of course, pre-COVID, we did a screening where we screened everyone. We sort of went out to the public sort of a weekend where we had an event, a local event, and then the Cardiac Society just set up a booth and anyone could come, partly because in Brunei we have a high-risk population group, even younger patients. We have up to a third of patients diabetes, almost a quarter of patients have, well, probably up to a third of patients have hypertension. So actually we are a high-risk population here. You see, so with diabetes, hypertension, the chance for us is at least 1, so which qualify for some anticoagulation. But in terms of longer term, we are quite keen on screening for AF, but we haven't kind of decided how we are do it, because we are in discussion with our GPs, because a lot of times when they detect it, they usually go via the GPs. So we'll have to get them on board, and then once a referral pathway, sort of the pathway of once we've detected all these things, and perhaps we have a few of these ECG based, ECG and mobile phone based machines, which we are thinking of potentially lending it to communities, and we have a lot of NGOs who are interested. So we are working on that. So at the moment, that's where we're at, though, because again, with COVID, a lot of things are kind of on hold.
Okay, thank you. So I think maybe that's a trend or a next move for every country or region in the Asia Pacific area can have such kind of program to screening the patient, high-risk patient for atrial fibrillation, so then they can reduce the risk of stroke. So thank you again, Dr. Lim, for your nice talk and discussion. So let's move to the next talk. The next talk will be presented by Dr. Sunu Budi Rahario. And Dr. Sunu will talk the reason control strategy prevail rate control in early atrial fibrillation management, true or false. Dr. Sunu is now the chairman of Indonesia Heart Rhythm Society. Let's welcome Dr. Sunu. Dr. Sunu, please.
Thank you, Professor Ming, Professor Rikarasi, and the organizing committee of this APSC Cloud meeting. Could you see my slide, Prof?
Yeah, we can see your
Yes.
slide, but actually it's in presenter mode, not you may
sorry.
switch. Yeah, please
Okay.
switch. Okay, now you can make a full screen.
Okay, just wait.
Okay.
This is full screen or? presenter mode.
No, still in the presenter mode, which means you need to end the slideshow. No, display setting.
Okay.
Make a
So
different. Okay, now it's
yeah,
come
I
back. Okay,
continue.
great.
Okay.
Okay,
Thank you.
continue, please.
Thank you to the organizing committee who give me the opportunity to share about this rhythm control strategy prevails rate control in early AF management, true or false. Based on this ASC guideline 20 and 20, once we diagnose AF, as Dr. Lim has mentioned regarding the detection and diagnosis, then we need to characterize the 4S and AF scheme, the stroke risk, symptom severity, and AF burden and substrate severity. And then we need to treat the AF based on the ABC pathway, avoid stroke, better rhythm symptoms control, and treat the comorbidities and risk factors. Today, I would like to focus on the rhythm control. So based on the guideline, stroke prevention, comorbidities management, rhythm control, and rate control. So is it rhythm control compared to rate control will give better treatment for the patients? Let's take a look on the current data or current publications. For this strategy, the rhythm control include AF ablation, antiarrhythmic drug, and cardioversions, while the rate control strategy include the drug for the rate control, and also probably we also need to do AV node ablation and pacemaker. In each of component of this strategy, these are the list of the strategy or technology or approach that we could do, like AF ablation, we could do PV isolations, surgical ablation, or hybrid ablation, while for antiarrhythmic drug, the choice are limited to this, and especially in my country, in Indonesia, actually we only have this imiodaron and propafenone. And for the rate control drug, we have a beta blocker, non-adherent calcium channel blocker, and digoxin. The issue is when we need to do the rhythm control and when we need to do the rate control. And or in early, especially in the current question is for the early AF, rhythm control first or rate control first. This is one of the publication in 2002 in New England Journal of Medicine, the AFFIRM study, which showed that actually the rate control is not inferior or even better in the cumulative mortality, although the p-value is not significant compared to the rhythm control. And this trial is used for many years to justify that rate control strategy could be used as a treatment to manage the AF, even if it is in the early AF. And let's see the data that we have in 2020. So 18 years after that AFFIRM study, there is a publication also in the same journal, New England Journal of Medicine, the IS-AFNET 4 trial, which showed that early rhythm control therapy in patient with AF. So there are 110 patients and divided into the rhythm control strategy and rate control strategy or usual care. The rhythm control strategy include here 8% with AF ablations and then 60% with dronedarone, 20% with imiodaron, and majority with flecainide, 36%, and others with propafenone and other antiarrhythmic drug. While for the initial or the usual care, they use only rate control strategy. But actually in this proportion were changed after 2 years, while for the rhythm control strategy changed to 19% with the AF ablation, and also 2 years later in the usual care with AF ablation in 7% of the patients. But majority of this rhythm control strategy was using the vertical night. If we look at this data, after 5 years of observation, the trial was stopped because there is a clear benefit in the early rhythm control strategy in the cumulative evidence of stroke, cardiovascular deaths, and hospitalizations with a hazard ratio of 0.79. If we compare this data, the AFM study and ISFNet study, actually the mean age of the patient was similar, around 70 years old, but we could see the difference clearly that in the ISFNet trial, 30% with the symptoms, while for the AFM study only 6%. And then the utilization of the ablation is 19% in the ISFNet trial, and in the AFM only 0.7. Of course, we understood that in 2002, the technology for ablation is far behind the current technology that we use. These are the main finding of this trial, ISFNet-4 trial, that shown that this is the usual care and this is the early rhythm control strategy. And we could see the benefit with almost 30% reductions in death from cardiovascular cause and also from the stroke in the early rhythm control strategy. Therefore, for the better symptom control in the management of AF, in the ASC guideline 2020 recommended rhythm control therapy is recommended for symptoms and quality of life improvement in symptomatic patient with AF. But based on this ISFNet-4 trial, actually it is not only for symptoms and quality of life improvement, but also for the benefit of cardiovascular mortality and stroke. In our data in Indonesian Registry on Atrial Fibrillation or 1AF, we just published last year, we could get that the number of patients with symptoms, this is a hospital-based registry, so we could understand that most of the patients were symptomatic, 84%. So if we could do the early rhythm control strategy, then these symptoms may be better control. This is AF ablation and then antiarrhythmic and cardioversions. And this trial, the ISFNet-4 trial, used this AF ablation and long-term antiarrhythmic therapy. I will briefly mention about the rhythm control in acute AF using the cardioversions. So this is the strategy how to do cardioversion if we have the patient with acute AF. If the patient is more dynamically unstable, then we could directly do emergency electrical cardioversions. But if it is hemodynamically stable, then we have to check the oral anticoagulant status and then decide whether we do directly or with electively for after 48 hours of the anticoagulant, and then decide to continue oral anticoagulant or not. And this the guideline showing the indication for catheter ablation in symptomatic AF. In symptomatic AF, if the status of the AF is paroxysmal AF, first consider the patient choice using the antiarrhythmic drug, and then fail, remain symptomatic or remain recurrent the AF, then will be in the class 1 indications. But also this is class 2A indication for perform catheter ablations. But for persistent AF without major risk factor, it is class 2B. While for the paroxysmal AF with heart failure, I think the next speaker will talk about this, it is class 1 indications. This study, meta-analysis of the radio frequency and the cryoablations between catheter ablation versus other modality for rhythm control. Still here we can see that the cumulative risk ratio was better if we do the catheter ablation compared to antiarrhythmic drug. And these three meta-analysis only narrowing down for the cryoablation, the cryo first, early AF, and stop AF first. And those are same that show that the catheter ablation, whether using radio frequency or cryoablation, will give benefit for management. So in the AF guideline, ASC 20 and 20, when performed by appropriately trained operator, catheter ablation is superior alternative to antiarrhythmic drug for maintenance of sinus rhythm and symptoms improvement. And first-line therapy for the paroxysmal AF and persistent AF without major risk factor for recurrence. This the risk factor that favor the rhythm control, younger age, and then first AF episode, tachycardia mediated cardiomyopathy, normal moderate LAVI. And this is the continuous. And interestingly, just last week, there's a publication of the sub-analysis of the East Afnet trial by Dr. Gute, presenting pattern of AF and outcome of early rhythm control therapy. So they divided that the early AF into three. First episode, paroxysmal and persistent AF. Because actually, if we look at this spectrum of the early AF were included in the first onset and then paroxysmal and persistent. And they found that among these three early onset, early AF, in the first episode of AF, if we do early rhythm control, actually the outcome of the hospital coronary syndrome and secondary primary outcome of hospitalization were higher. But if it is paroxysmal or persistent AF, this early rhythm control strategy is better. That's why in the editorial view, Dr. Stefan mentioned that for paroxysmal and persistent AF, if the AF episode is still less than 1 year, it is first recommended to use the rhythm control. But if it is first diagnosis AF, rhythm control is have a below level of evidence compared to this paroxysmal or persistent AF. As a conclusion, the early rhythm control strategy resulted in reduction of primary combined outcome of cardiovascular death, stroke, and hospitalization for heart failure and acute coronary syndrome as compared to the rate control strategy. But this early rhythm control benefit was found mainly in the paroxysmal and persistent AF, but not in the first onset of AF. Thank you.
Okay, thank you, Dr. Rahayo. So your nice talk. So is there any question from the panelists or online audience? So if there is not,
Dr.
may I
Suno?
ask, yes?
May I ask one question, Dr. Suno? In
Yes.
paroxysmal atrial fibrillation, how long would you anticoagulate the person after conversion to normal sinus rhythm?
Okay, thank you, Dr. Sabat Sarwa. Thank you for your questions. Personally, for the paroxysmal AF, after we do ablations, I will check Holter monitoring for 3 months and then 1 year. And after 3 months, if I do not see the episode of AF in that period, and if the CHATFA score is quite a low risk of the AF, then I may stop it. But if the patient still have a high CHATFA score, then we need to consider individually. Sometimes we need to check the longer episode of duration of the Holter monitoring, then decide whether we will stop the anticoagulant or not. It's my current practice, Dr. Sarwar.
Thank you.
Thank you.
Yes. So Dr. Rahayo, so why? So you have just mentioned about the East AFNet T4 trial, the recent publication talking about the how early we should get a rhythm control for atrial fibrillation patients. So why the first episode is not so good as the persistent or paroxysmal AF patients? Is there any?
Yes, thank you, Professor Ming.
Mentioned?
Yeah, actually, they don't have really the data regarding the reason why the first episode has different outcome compared to the paroxysmal and persistent, which is less than 1 year. But in the discussions and also the editorial, they mentioned that probably for the first episode may be related the occurrence of AF itself may relate it to the acute cardiovascular illness. For example, acute coronary syndrome or acute heart failure. That's why the outcome is a composite outcome, then it is probably related to the acute illness. This is the discussion that they mentioned, Professor Meng.
So follow this question. So in your experience, how do you measure? You will treat the first episode until, for example, 6 months later, or observe 6 months later, or 1 year later, 1 year later with drug, with anti-arrhythmic drug, and then if the patient have a recurrence atrial fibrillation, then you will suggest patient to undergo a catheter ablation.
Well, actually, this study just published 2 weeks ago, Prof. So, yeah, this is the new data that I just got when, we try to improve our management of the patients. But as a practice, if the episode of the first onset is related to the current illness, for example, because of acute coronary syndrome or acute heart failure, then maybe I will wait like 2 months using antiarrhythmic drug. If it is still recur, then we may think of this catheter ablation. But for the one who have no current acute illness, I think this is just my personal opinion. I think we could apply this as a paroxysmal AF, not truly first onset AF due to the current illness. This is my opinion. What do you think, Prof?
Yes, I think so. I will try medication first, and then observe them, the effects, efficacy of them. So the second question is, do you use twice medication such as propafenone plus amiodarone in patient to convert the atrial fibrillation in your practice?
Yeah, actually the medication of antiarrhythmic drug which are available in my country is only amiodarone and propafenone. My current practice is usually first I try the first using the ritmonorm or propafenone, but if the patient is still symptomatic, then I will combine also with the amiodarone, but not directly combine.
Yes. So if there is no more further question, I'll thank Dr. Rahayo again. Thank you very much for your presentation and answer. Thank you.
Thank you. Okay. Thank you.
So let's move to the third talk. The third talk will be presented by Dr. Toshiya Kojima from Japan. Dr. Kojima is assistant professor, Department of Cardiovascular Medicine, the University of Tokyo, Tokyo, Japan. So Dr. Kojima will talk the reason control strategy prevails rate control in half rev or half PEF with atrial fibrillation. True or false? Dr. Kojima, please.
Thank you, Professor Lin. I share my slide.
Yes,
yes. I'm proud of this opportunity and appreciate to the president and the chairperson of APSC. I'd like to make presentation and discuss about atrial fibrillation and heart failure, or especially HFrEF and HFpEF. Atrial fibrillation patients are expected to be more common than previously thought, and it is all report. The number of atrial fibrillation cases in Japan is expected to exceed 1 million in 2050. And not only AF, but also heart failure pandemic are widely enlightened to the public in the world. There is no objection that sinus rhythm is preferable and should be maintained in heart failure. Generally, there are 3 treatments for atrial fibrillation: stroke prevention, heart rate control, and rhythm control. In 2002, the result of the AFFIRM study was reported. Rhythm control with antiarrhythmic medicine was not significantly different from heart rate control in mortality. And they are the same as event-free survival. Results of the ALCSF study were reported in 2008. In heart failure patient, rhythm control with antiarrhythmic medicine compared with lead control showed no significant difference in deaths and their stroke and their worsening heart failure or composite outcome. So therefore, until the 2000, heart rate control was considered sufficient for atrial fibrillation treatment in heart failure. However, in the 2010s, the importance of maintaining sinus rhythm in heart failure was reported. Rhythm control of atrial fibrillation is necessary for effective use of beta blockers for heart failure. And this is largely due to advances in treatment of atrial fibrillation. As you all know, in 1998, it was reported that many of the causes of atrial fibrillation originated from the pulmonary veins, and the pulmonary vein isolation was established for atrial fibrillation. PABA-CHF was reported in 2008. Ablation confers superior outcomes on LVEF, or 6 minutes walk, and quality of life in heart failure with drug-resistant AF. AA-TAC trial was reported in 2016. Ablation was superior to amiodarone in AF recurrence, emergency hospitalization, and death at 2 years follow-up. Very famous CASTLE-AF trial was reported in 2018. Ablation for AF reduced all-cause mortality, heart failure, hospitalization, and cardiovascular deaths, and their composite endpoint compared with medical therapy. I present one simple case of heart failure. Our patient was a 26-year-old male. When he developed heart failure, he had AF with first ventricular response and decreased left ventricular systolic function. We suspected brachial-induced cardiomyopathy and performed ablation. After pulmonary vein isolation, he maintained sinus rhythm. His cardiothoracic ratio was lowered and BNP was markedly reduced. As you know, his left ventricular contraction improved markedly and it became normal. The concept of TIC is well known. However, the biggest problem is that this disease is often retrospectively diagnosed after treatment. We will consider the remaining issues. First is applicant indication. And the previous report has mostly been for HFpEF. However, there are also a few reports of HFpEF. This is a report of atrial fibrillation and HFpEF in 2018. Atrial fibrillation is associated with increased mortality risk in not only HFpEF but also HFpEF. Hazard ratio is 1.39, P is 0.022. The prevalence of AF with HFpEF significantly increased worse mortality and heart failure hospitalization. And the Kaplan-Meier survival analysis demonstrated a significant mortality increase in patients with HFpEF. However, the higher mortality was restricted to the patient group receiving AV node ablation. LA ablation induced a significant mortality decrease in all groups. Today's theme is HFpEF and HFpEF. Better, heart failure is not just left ventricular ejection fraction. This is our data of AF with ventricular valvular heart disease. And their MR and PR improved with F termination and the sinus lesion recovery compared with AR. Early intervention for AF is considered useful for valvular disease caused by discoarctation. Next issue is ablation strategy. Many ablation strategies have been considered in addition to PVI. Many ablation strategies have been considered in addition PVI. And the most representative one is linear ablation. The result of STAR F2 was reported in 2018. This is very shocking. Their PVIs, PVI, only PVI, isolation plus electrocardiograms and isolation plus lines. There are no significant changes of freedom of atrial fibrillation. The remaining problem is that PVIs is only treatment for persistent atrial fibrillation or not. And the problem here is a low success rate of linear ablation. Ablation strategies for persistent and longer-lasting atrial fibrillation remain chaotic. Add-on therapy to pulmonary vein isolation is a tailor-made stage for atrial fibrillation at this time. Next problem is a result for maintenance of sinus rhythm. This is a result of maintenance of sinus rhythm with persistent AF and decreased EF in our hospital. Improvement in left ventricular function is observed, but maintenance of sinus rhythm is an issue. If patients are expected to maintain sinus rhythm over multiple sessions, however, by the improvement of treatment results is a challenge. This is I would like to present case 2. He is a 35-year-old male, and he had shortness of breath on exertion and reduced elbow EF, and he was diagnosed with DCM. After that, he had second-degree AV block and implanted CLD. After that, we ablated for persistent AF. We performed simple PV isolation. PV isolation was performed, but sinus rhythm could not be maintained, and F leaked early. Cardiac overload due to ablation exacerbate heart failure. For some time, he became catecholamine dependent. Immediately after ablation, not only invasive burden of treatment, but also heart rate drop and heart rate drop, lack of atrial kick, and the diastolic dysfunction are suggested. And there, we have countermeasures. One is collaboration with heart failure team. For some patients, heart transplant legislation may be considered in some cases. And there are administration of catecholamine before surgery to improve the condition. This is our last message from me. Rhythm control strategy prevails leg control in half left or half back with atrial fibrillation. True or false? True. That carefully consider indications. And early treatment of AF is desirable to improve outcome. In particular, take care of severe heart failure, for example, stage 4, or in some cases, proceed with transplant legislation in advance. And adding other treatment to PVI is tailor-made medicine. Thank you very much for your attention.
Thank you, Dr. Kojima, for your excellent talk to let us understand the role of atrial fibrillation rhythm control strategy in patients with half ref or half PEF.
Yeah.
So is there any question from the audience or panelists?
Yes, I would like to add one comment and one question. My one comment is that in all the studies we are seeing till now, I'm a cardiovascular imaging person, so we are now using left atrial volume index for measurement of left atrium because the size, simple anterior-posterior dimensions cannot determine left atrial dimension most of the times. So most of the studies are using left atrial size. We should be using left atrial volume index. That is one comment. And my question is that in our countries, this electrophysiologists are not very busy right now because people are not really aware of the implications of rhythm control in large scale. So they are generally referring to rhythm control medicines. And unfortunately, we have only imodron in our country. So for how long? Because we know the side effects of imodron. So for how long can we continue? And if there are side effects, then what to do? Please.
Thank you very much for your comment and the question. As you said, there complication side effect of amyloid is a very large problem for us, especially lung injury and their thyroid toxicity. So we use amiodarone. We have many cases of sotalol rather than amiodarone, but sotalol is a stronger beta blocker effect rather than amiodarone. So we have to take care, take much care of sotalol for heart failure patient. But the expert doctor of heart failure prefer to increase beta blocker, carvedilol or bisoprolol. So we use antiarrhythmic medicine to maintain sinus rhythm at the arm or fibrillation. Better if we keep sinus rhythm, we prefer to decrease antiarrhythmic medicine.
Okay. Yes, Dr. Kojima. So how do you, what is your experience in doing the catheter ablation for the patient with half ref? What is the determinant factor of recurrence of atrial fibrillation in your laboratory? Is that the enlarged LA or something?
Yeah. Of course, large area size is the limitation for indication of PVI, but not larger than 50 millimeter diameter of LA. We try to cardioversion of AF, and after that, if their sinus rhythm is maintained, we perform catheter ablation for them.
Yes. So
Can I ask question?
Yeah.
Yes,
sorry.
yes, please.
What is your strategy for long-term persistent atrial fibrillation? So do you add some linear ablation or cafe ablation after PV isolation?
This is a big problem for electrophysiologists, and previously we perform PV isolation plus linear ablation. Sometimes broadside ablation of posterior wall of LA. But recently, at first, we perform simple PVI at first. And if there is a recurrence of AF, we perform second session. We separate two sessions because for heart failure patient, their overload of treatment is a big issue. So to divide two strategy, we reduce that overload of treatment for heart failure patient.
Thank you.
Okay, is there any other question for Dr. Kojima? Okay, if not,
can I
yes.
ask? I'm sorry.
Sure, please.
You showed two cases, two representative cases.
Yes.
In second case, did you perform MRI, cardiac MRI? So in that patient, is there any LG?
Yes.
So because I think it is difficult to differentiate tachycardia-induced cardiomyopathy or dilated cardiomyopathy before ablation, before rhythm control.
Yeah, that is very important problem. When he diagnosed as a DCM, he was performed MRI. MRI was performed for him, and there are some deleting enhancement of MRI, but we cannot perform. We could not perform MRI just before PV isolation because CLTD was implanted. So now CLTD is useful for the bus patient, but in that time, his CLTD was not for MRI. So I cannot just before CLTD, but previously MRI was performed, and we detected LG.
So I think if there is LG, I think such patient is maybe DCM and no LG heart function may improve after rhythm control. I thought so.
Yeah, thank you very much.
Yes, and Dr. Kojima, so when you have undergo catheter ablation for patient with heart failure patient, and you got a success rhythm control for them, but how do you maintain them? And what is your experience in your case series? How many patients have to undergo a second section or even third? And how do you management them?
As I showed the result of catheter ablation, for many patients, they need multiple sessions of a PVI. So I hope to maintain syncretism. Sometimes we add anti-allopathic medicine like sotalol or amidolone, but in many cases of heart failure, their blood pressure is low. So sometimes we have the difficulty to increase anti-allopathic medicine and their beta blocker. So the other remaining problem about that.
Yes. So how usually in your series, how long is the sinus reason period after successful catheter ablation in the first section? Is lasting for
yeah.
two years or third year, 3 years?
Here.
In
I check the many patients in outpatient clinic, and many patients keep sinus rhythm after 1 or 2 years, and it is difficulty to keep and maintain sinus rhythm is early period, and after the recovery of heart failure, it is easy to maintain sinus rhythm rather than early stage. So it is a problem that we keep sinus rhythm just after treatment of AF with PVI.
Yes. Okay, thank you. So thanks, Dr. Toshiya Kojima again for your excellent talk and discussion. So let's move to the fourth talk. So I will invite Dr. Miyako Igarashi to chair the last two talks. Dr. Igarashi, please.
Thank you, Dr. Wen. I will chair the last two papers. The next speaker is Dr. Il-Yong Wo from Korea. The title is Cryoballoon Catheter Ablation Prevails Radiofrequency Catheter Ablation in Atrial Fibrillation Interventional Therapy, True or False? Dr. O, please.
Okay, can you hear my speak?
Yes.
Okay. Okay, let me share my slide. Okay, can you see my slide?
But yes, but not
Okay. Yeah,
yes,
thank
yes.
you.
Okay.
Thank you, Chairman. I am Il-Young Oh. I work in the Seoul National University Bundang Hospital in South Korea. I am very honored to have a chance here. Today, my talk is about the cryoballoon catheter ablation, prevail RF catheter ablation in AF interventional therapy, true or false. It's like which one is stronger, lion or tiger? And in some Korean television series, the extraordinary attorney Wu said it's like a comparison between the blue whale and humpback whale. If you see this drama TV series, you can know what I said. Okay, so far, catheter ablation got us some recommendation level is 2B in case of the paroxysmal AF with symptom, and in case of the persistent AF, the recommendation level is 2C. And AF catheter ablation in the patient with LV dysfunction is a class 1 indication. Level of evidence is B. And if the patient have a AF-related bradycardia or symptomatic pre-automatic pause after AF conversion, recommendation level is 2 and level of evidence is C. So about 20 years ago, one study showed the rhythm control efficacy in the study compare PB isolation with the RF energy and the anti-arrhythmic drug group. So each 30 patient, about approximately 30 to 40 patient enrolled in each group, pulmonary vein isolated group and anti-arrhythmic drug group. So at the end of the 1 year follow-up, 63% recur with the patient who received anti-arrhythmic drug. However, the patient who underwent PB isolation using the RF energy, just 30% recur. So this study showed the PB isolation with RF energy is superior to the antiarrhythmic drug for the sinus rhythm maintenance in the patient of AF with paroxysmal AF. Maybe very small portion of the patient got a persistent AF, and mainly the patient who enrolled this study is a paroxysmal AF. However, in this case, asymptomatic mild or moderate PV stenosis was documented in the 2 patients of 32 patients in the PBI group. And 10 years ago, another study showed the efficacy of the PB isolation in the paroxysmal AF. More patients enrolled compared with the previous study of approximately 150 patients enrolled in each group, ablation group and drug therapy group. The mean age is 56, more older than the previous study. However, there was no significant difference between the ablation and drug therapy group before 12 months. However, after 12 months, the burden of AF significantly lower in the ablation group. The p-value is the 0.007 is with the significant statistical significance. The ablation group is better than the antiarrhythmic drug. However, in the ablation group, there is 1 death and the 3 cases of cardiac tamponade. 1 year ago, 2 papers published in the NEJM, 2 papers also evaluate the efficacy of the cryoballoon ablation compared with the antiarrhythmic drug. So in this case, the mean age of the patient was about 60, so more older than the previous study. So ablation group efficacy is the 74 and drug therapy efficacy is 45. And just the 2 primary safety endpoint events occurred in the ablation group. So less complication, but similar, the high efficacy, similar with the RF catheter ablation. And next study, also published in the NEJM 2021. This study, the mean age of this study is the 57 or 59. And at 1 year, arrhythmia recur in the just 43% in the ablation group and approximately 70% recur in antiarrhythmic drug. And the serious adverse event occurred in 5 patients, 3.2% who underwent ablation, and 6 patients, 4.8% 0% who received antiarrhythmic drug. So the serious adverse event rate is similar in both groups. So indirectly, I compare the RF energy, the study which was using the evaluate the RF catheter ablation, and another study which evaluate the cryoballoon ablation. So Mantra PAF, as I said, which was published in 2012, and another study, Early AF, which was published in 2021. The mean age of the patient similar, about 56 in RF study and about 57 in cryoballoon study, and similar hypertension in incidence and the LA size also similar in both study. So Mantra PAF, as I said, before 12 months, this study did not show the superiority of the RF population compared with the antiarrhythmic drug. However, after at the 2 year, the ablation with RF is superior than the antiarrhythmic drug. And cryoballoon, in case of the cryoballoon study, they showed just after 4 months, the superiority of the cryoballoon ablation, showing this study. And the adverse event, 1 death and 3 tamponade occurred in ablation group. However, RF ablation group. However, in cryoballoon ablation group, there is no death and there is no tamponade. So when I compare this study, cryoballoon ablation got a more similar efficacy with the RF study, RF energy. However, the less complication compared with the RF ablation. And another comparison between the RAPT2 and STOP-AF trial. In cryoablation study, more older patient enrolled to the cryoballoon ablation study. LA diameter similar, but slightly smaller in the cryoablation study, and the hypertension incidence is 42, and more hypertension patient enrolled in the cryoballoon ablation study. The recurrence rate is 72 antiarrhythmic drug and 54 in ablation group, and similar result. So this comparison showed that the similar efficacy between RF and cryoballoon ablation. However, the complication, especially in case of tamponade, more tamponade occurred in the study using the RF energy. Just 1 case in the cryoballoon ablation case. So less tampon occurred in cryoballoon ablation than the RF ablation. And another study direct compare the cryoballoon ablation and the RF ablation. So the mean age of this study is 60, and the same profile between 2 groups, and the similar efficacy between 2 group, RF group and cryoballoon group, about 35% occurred AF recur in the patient. However, in case of the complication, especially tamponade, as I said, more tampon occurred in RF group compared with the cryoballoon ablation group. In case of the cryoballoon ablation group, 2 deaths, but the deaths were not related to the treatment or device. So 1 death of unknown cause, another death is associated with sepsis. So definitely the less tampon occurred in the cryoballoon ablation technique more than the RF ablation technique. And another subgroup analysis, a patient 374 subjects in the cryoballoon group and 376 subjects in the RFC group were evaluated in the modified ITT cohort. After index ablation, repeat ablation and direct current cardioversion and all-cause rehospitalization and cardiovascular hospitalization, the more safe in cryoballoon ablation group compared with the RF group. So main primary endpoint similar, but in ITT analysis, cryoballoon is superior than the RF ablation in case of the repeat ablation and direct current cardioversion and all-cause rehospitalization and cardiovascular rehospitalization. So there is some complication in cryoballoon ablation. So there is no fraying nerve injury in case of the RF ablation, but some report about 8% of the fraying nerve paralysis. However, usually this fraying nerve paralysis is recovered after 1 or 2 years. So fraying nerve paralysis, it doesn't matter usually. And in our data, some myocardial damage after ablation. So troponin I, 1 day after cryoballoon ablation, usually 8.4 nanogram per milliliter, but usually it doesn't matter. So let me share the Korean study, cryoballoon ablation registry study. These study results will be published in Korean Circulation Journal of this year. So in the South Korea, three main centers who performed the cryoballoon ablation attended this study. So patient baseline characteristic, totally 300 patients were enrolled in this registry. The mean age is 60, and 0.5% is the paroxysmal and 0.5% in persistent AF. LA diameter, mean LA diameter is 43. And hypertension is 50%, and DM is about 20%. So procedural characteristic, total lab occupancy time is 114 minutes, and total procedure time is 76. Usually, in case of the RF study, about 120 hours usually take, but in case of the cryoballoon, more shorter time was needed. So a number of patients with AF, A-flutter, A recurrence rate is at the 12 months of recur rate is 30%, similar with the other RF catheter-based study. And the safety event, there is no pericardial tampon and pericardial effusion, and just 3 cases of fraying nerve injury, and no serious adverse event reported in this Korean registry. And AF recurrence rate similar with the RF result, RF-based catheter ablation result, and another study result was similar with that. And this is today's my schedule. So before this talk, I finished the morning process, 1 PSVT case and 2 cryoballoon ablation case. So it usually take 1 hour. So my procedure, today's procedure started at 9 a.m. But before my talk, I finished my cryoballoon ablation procedure. And after this talk, I will perform a RF case. This case is a recur case. So in my lab, usually the patient who underwent first ablation I usually recommend cryoballoon ablation, and then if the patient recur, in that case, I perform a RF ablation with 3D mapping system. And another point, region formation with cryothermal ablation. This study was published last year in JACC. So this study showed the greater quality of life improvement in cryoballoon ablation and reduced recurrence of atrial tachyarrhythmia and similar rate of the adverse event. But in case of the tamponade, cryoballoon is superior than the RF ablation and reduced healthcare unit utilization and reduced hospitalization. So cryothermal energy offers several advantages when compared with RF energy, including freeze-mediated catheter adhesion, which facilitated catheter stability in challenging regions such as the ridge between the left atrial appendage and PB, and well-demarcated homogeneous region that is thought to be more durable and less arrhythmogenic than the indistinct region associated with RF ablation. And third, minimal endocardial surface disruption, which is less thrombogenic than the lesion produced with RF energy, and preservation of the ultrastructure tissue integrity, which may lead to reduce the risk of complications such as cardiac perforation and exposure injury, pulmonary valve stenosis. So I will share my two cases, which cases combined with another procedure. So the first case, cryoballoon ablation plus a CRT implantation, and another case, cryoballoon ablation plus LA appendage occluder case. So the male patient 63, heart failure with atrial fibrillation, and LV end-diastole is 56 millimeter and ejection fraction 19%. ECG showed the atrial fibrillation with the left bundle branch flow. So 9 months optimal medical therapy. However, AFib continue and the left bundle branch block still continue. So this cardioversion performed. So the sinus rhythm the AF terminated and sinus rhythm are observed. However, AF recur with the amiodarone treatment. So I will perform I perform a cryoballoon ablation plus CRTD because of the patient got a heart failure and left bundle branch block. So at first perform a cryoballoon ablation and then perform a CRT implantation. So after CRT ablation plus CRT implantation, QRS is decreased and the sinus rhythm maintained. And 9 months later, amiodarone off 8 months later of the procedure, sinus rhythm maintained and QRS also decreased. So the chest pace change before the CRT treatment and after CRT, 11 months after CRT, cardiomegaly decrease. So an echocardiography showed the ejection fraction improved after CRT plus cryoballoon ablation. So cryoballoon, in case of the cryoballoon ablation, it takes a shorter time compared with the RF ablation. So very useful for the combined procedure. Another case is a male 59-year-old and recurrent stroke during the NOAC treatment. So I will cryoballoon ablation for the persistent AF followed by left atrial appendages. So at first, cryoballoon ablation performed, and then LA appendage occluder implantation was done. So before cryoballoon ablation, I usually perform some simulation with the 3D printed left atrium. So this is a summary slide. Compared to RF ablation, cryoballoon has the following characteristic: similar AF reading control, and a shorter procedure time and fewer complications, especially lower incidence of the pericardial effusion, and easier to combine with other procedures such as left atrial appendage occluder and CRTD procedure. And I think the more shorter learning curve was needed for the cryoablative ablation case. Thank you for your attention.
Thank you, Dr. O. Nice presentation. Is there any question or comment from the panelists or audience? Can I ask a question? In your country's survey, 40% of the patient didn't receive CT, cardiac CT or MRI before ablation. So how do you decide the indication of the cryoballoon ablation?
Yeah, there is some technical issues, so I didn't hear your first part of the question. So could you again?
So in your country's survey of cryoballoon ablation, 40 patients didn't receive CT, cardiac CT or MRI before ablation. Did you hear?
Yeah, I hear. I can hear you. Yeah.
So how do you decide the indication of the cryoballoon ablation? So, for example, some patient had common PV, pulmonary veins, or dilated antrum, or so I think it is difficult to do cryoballoon ablation. So how do you decide?
Right. Thank you for your good question. In case of the common left ostium, and if the patient got some huge pulmonary vein ostium, there is some technical issue of the cryoballoon ablation case, but it can be overcome with the experience. So as I said, in the first ablation of atrial fibrillation, I usually perform a cryoballoon ablation. I choose the cryoballoon ablation all the patient. Yeah. So yeah.
Is it? I think it is difficult to big PV.
Right. In that case, in that case, the segmental ablation using the cryoballoon is first time anterior loop, and the second time inferior and the posterior wall. So maybe with the there is some needs to skill, but maybe 10 or 20 case, if you experience 10 or 20 case, you can perform a segmental ablation in the huge PV or common ostium.
Okay, thank you so much. Any other question from the panelists or audience? So 30% of the patient had recurrence. So did you perform the second ablation?
Usually, but it depends on the patient characteristic. If I think in the case, if patient got a long history of the atrial fibrillation, sometime I didn't perform a ablation. But if the patient, a younger patient and the shorter time, in that case, I perform a second ablation. In that case, I use the RF energy technique.
Ask that because I would like to know the reason of the cause of the recurrence. So people, how many cases, how many percent of people reconnection after PV isolation?
Yeah, in the first period of the cryoballoon ablation, the reconnection of PVI in case the left superior pulmonary vein, if the patient very high angle, in that case, the ridge area, it is very difficult to touch the edge area using the cryoballoon. So the first reason, and the second reason is the right middle pulmonary vein. In the first period of my cryoablation, I didn't perform a middle pulmonic vein ablation, isolation, but after I experienced many recurrence cases in the right middle pulmonary vein, I usually perform a right middle pulmonary vein. If the patient got a right middle branch, in the case, I usually perform a right middle pulmonary vein isolation.
Actually, I agree with you. Right middle vein is bad. Any other question? Okay. Do you have any comment, Dr. Wen, Professor Wen?
No. Thank you.
Thank you so much. Next presentation. So thank you, Dr. O. So I will move next case, next paper. So next speaker is Dr. Man Chandavimo from Thailand. So the title is Device leak is Achilles tendon of LAAO therapy for thromboembolic risk prevention in drug refractory atrial fibrillation, true or false? So Dr. Chandavimo, please.
Hello, you can hear me and see my slides?
Yes.
Okay,
I can.
hello. Yes, so yes, my name is Man Chandavimo from Ramatipati Hospital, Mahidol University, Thailand. My assigned topics today is to be regarding the peri-device leak, is Achilles tendon of LAO therapy for thromboembolic risk prevention. This is my disclosure. So just to put on the background of the data on the LAO and stroke prevention, you all probably know this. This is a 5 years outcome from PREVAIL and PROTECT AF trials, which randomized patients to Watchman device and vitamin K antagonists. And this pool data show that Watchman is had preferred in or favors in terms of non-procedural related major bleeding, reduced hemorrhagic stroke, quite equivalent in terms of all stroke, and kind of on the edge of inferior to warfarin in terms of ischemic, but it wasn't past the line of unity. And since then, there's a few other ways of occluded the left atrial appendage. This is one of the important study, which is a surgical LA occlusion during cardiac surgery. So the patient whom underwent cardiac surgery underwent LA occlusion versus non-LA occlusion, and with a follow-up of 72 months, LA occlusion has shown to reduce the risk of stroke or systemic embolization significantly. On top of that, we have moved from vitamin K antagonist to DOACs in the current practice more and more. This is the data comparing LA occlusion to DOACs. It's 3 trials of plaque 17 and 2 other trials with the pool data of 1,360 patients. With a 98.8% implanted success rate. We found that when compare LA occlusion, which all these 3 trials is a combined Watchman and amulet device, show that the risk of ischemic stroke or thromboembolism was no change, but had significant reduction in ISTH major bleeding, and no different in death or cause mortality. So no compromise in efficacy, but reduced risk of bleeding. Nonetheless, the most recent American guideline in 2019, the use of LA occlusion for stroke prevention is still class 2B with level of evidence B then. However, the devices has been FDA approved since 2015, mainly Watchman device in the States, and you can see the accumulative numbers of patients is increasing significantly over the years. And with that, we have had more data that any complication rate from the procedure is about 2.2%, and as compared to the expected rate, it had ischemic stroke reduction of about 77% relative risk reduction. And then that come along, if the per device leak is important, is that true or false? When we look back, the incidence of the per device leak, this is a Protect AF trials. You can see that per device leak at 12 months is roughly about 32.1%. At 45 days was 40.9%. The degree of leaks in majority of leaks is 1.3 mm. And this is partly because when we deploy the device, one of the release criteria that we want the leak of our device leaks not larger than 3 ± 2 mm. So that's how we decide, we leave quite a bit of patients with some minor leaks around. With the Protect AF, it hasn't been shown that either minor, less than 1 mm, or moderate or severe, more than 3 mm leak had associated with stroke or systemic embolization significantly. However, there could be an outlier when you look at the Protect AF in terms of the use of warfarin. If the patient will continue on warfarin or discontinue, there's a significant higher proportion of patients who had continued on warfarin if there's any flow, residual flow, as compared to if you have no flow, there's more tendency to stop warfarin, and that could affect the results of no difference in stroke or embolization when you look at the leak. And again, with the NCDR LA registry in the US, with a lot of patients, this is 51,000 patients from 2016 to December 2019, show that the small leak in this has been shown of 0.5 mm of about 25%, no leak at all about 75%, and more than 5 mm leak is less than 1%. So this group of patients, 25%, has shown to have a modest higher incidence of thromboembolic or bleeding events, whereas large leak is not. And I guess that's the same reason as mentioned before, that this patient had high proportion that they will be maintained on anticoagulant. So this raised the concerns or the topics of interest today, whether this minor leak 0 to 5 that has been the leak that we had been accepted as a good result, is that good enough? When we look at another devices, that's the Watchman mainly. There's another amulet device from Abbott. It had a different design in that they have a lobe and a disc. So the mechanism of closing the appendage and the landing zone is a little different. With this prospective registry, about 1,000 patients found that any leak is roughly about 12.5%, which is significant according to this registry, lower than the Watchman registries or trials. However, in amulet device, if you look at more than or less than 3 mm Pala device leak, there seems to be a significant increase in stroke, systemic embolization, or death in the group that had a PDL of more than 3 mm compared to less, 8.1% to 4.7%. Another devices in the region is the Lambre device. There's a trials comparing Lambre to amulet and Watchman, and the residual, according to this trial, more than 3 mm has no zero in all devices. Surgical LA occlusion is not necessarily always successful, depends on type of closure. In the whether it's excision, but if it's a suture exclusion or stapler exclusion, you can see that there was a significant number of patients who had residual remnant of LAA or persistent flow. So surgical LAA also not necessarily had always complete occlusion. Nonetheless, it has not shown any difference in stroke rate, whether you have a successful occlusion or unsuccessful. So when we talk about peri-device leak, how it occurs, if you see the pictures up here, sometimes as we know, the appendage orifice or the landing zone is not necessarily round. It could be oval, it could be teardrop, it could be very irregular, and so they could have a peri-device leak. It could be due to incomplete coverage of the orifice or lobes. It could be because we undersize the device. It could be because of the device was off axis during deployment. It could be the incomplete endothelialization of the device or late migration of the device or suture knot, or the remodeling of the LA appendage itself after the closure. Also, a little different in terms of if we close it with the epicardial ligation, we usually, if there's a residual or recurrent leak, it usually due to gunny sac effect, as you shown here. Or even with the Ralliet device, which is the external or epicardial closure of the appendage, you can see that it can cause acute leak or late leak, and the significant increase in numbers of late leak, like not immediate after surgery, is higher. So it's not necessarily better when you do the external exclusion. And by theory, what's the effect of incomplete closure? So basically, we thought that the open pulse of the residual flow of the appendage can cause the turbulent flow adjacent to the device, and that could aggravate platelet and thrombus formation, and that thrombus can be formed within the appendage, and then that can get out of the left atrial appendage and cause a systemic embolization. When look at in which case that had more PDLs, this is using a Watchman device, we found that long-standing AF had more paravalvular leak, more than PDL para-device leak, more than no long-standing AF, increase in LA size, LA pressure, RVSP, MR, or elliptical left atrial appendage. Interestingly, also the degree of leak immediately post-implant and 6 weeks post-implant is higher, can be higher also. It's also similar in the sense of using the amulet device. The predictor of para-device leak at 8 weeks were permanent AFib, orifice to landing zone diameter, device lobe off axis, or being too compressed. So this is also another important part of it, is that, as mentioned, even though there's no leak at all at implant, but there's a reported case that the leak increased over time for the reason I told you earlier. It could be LA remodeling, could be a slight migration of the device. And so it's been important now that we know that this might impact outcome, that how to follow up this patient. TE had some limitation. Most importantly, I think, is operator dependent. In some cases, can have poor quality images, and sample plane could be challenging when it's crescent. Also, could be difficult to estimate sometimes. So it's operator dependent. There's ways to help with color scale adjustment using the 3D glass view, that you can see the leak easier, or 3D multi-planar reconstruction to clearly find the anatomic location and severity of the leak. It has been more use of CT assessment using a TD reconstruction, using 3D multi-planar reconstruction to clearly identify where is the leak. And also can, there's a study comparing the two modalities, CT versus TE. For sure, for the CT, not only para-device leak, they can also detect fabric leak, as you can see here. Whereas TEE, we can only just gonna see para-device leak. And that compare contrast patency on this comparison study, 51.0% still had patency in using CT and 34% using TEE. And all TEE PDL is seen on CT, so 100% sensitivities. And also with the CT, you could appreciate the reason for the leak, such as off-axis leak, whether it's fabric leak or porous device leak, as shown. Also, the size of the para-device leak is also different. This is a study to assess leak size assessment and found that using a CT scan, the size tends to be larger, 1.3 mm, as compared to measured by TEE. So that's also important. There's a study specifically looking at that. It's a randomized controlled trials called Swiss Pro trials, have about 100 patients in each arm and had a CT scan looking LAA patency, which had a clear definition of the density of the LA of more than 100 HU or more than 25% of the LA, and both have Watchman flex and amulet device, and divided them into peri-device leak, mixed leak, intra-device leak, or no visible leak at all. And what they found that these two devices had similar percent of patency, so same leak, but the mechanism of leakage is different. The mechanism of the mixed leak and the mixed leak or the para-device leak is more common with the Watchman flex device, whereas the intra-device leak is more common in the amulet arm. So just to recap, para-device leak is more common in the amulet, in the Watchman flex, whereas intra-device leak is more common in the amulet arm. Clinical outcome is in terms of stroke, systemic embolization or major bleeding was no significant at 45 days. There's also another study looking at impact on per-device leak on 5 years outcome. And as mentioned, initially we thought that less than 5 mm leak is acceptable, but this study showed that want to assess if that minor leak, like this case, that we tend to be quite happy just to leave with that impact on long-term outcome. And so this is a study just recently published of this 45 days TEE and 1 year's TEE of about 1,000 patients using a Protect AF, Prevail, and a CAP2, and divide the patient into 3 groups: no PDL at all, PDL more than 5, or PDL between 0 to 5 mm, and at 1 year. At 45 days, all the 3 groups had no difference, no leak or any leak. But as mentioned, over time, the degree of leak can increase. In the group of no leak at all, it can increase from 45 days to 1 year. And if it's less than 3 mm leak, it can also increase or decrease to be no leak. So basically, they could go either way. Could have more leak once you follow up to 1 year, or less leak. And that the study found that at 1 year, if you have any leak, it had been associated with increased risk of stroke or systemic embolization, 5-year rate of 5.9% compared to 5.1%, and that's a significant p-value. However, there was no significant in all-cause death. So I think that's giving the evidence that in general, we would accept minor leak, but now more evidence has shown that perhaps we have to do better at closing the appendage. When it happened, what to do? There's no randomized data, but this is how people had proposed. One, if we can close it, this is all the devices we can consider, plug device, coil device, or ADO2, or different kind of plug. This study by Silman showed that it really depends on the size of the PDL. If it's 4 mm, the coil may be better. If it's 5, endovascular plug, and if it's bigger, 14 plus on average, you can consider another left atrial appendage occluder. So this is the diagram. If you had small PDL, you may not need it, but if you had bigger one, between 3 and or bigger, you can do coils or plugs, or if you have very big, you can have another closure device. So I think in terms of management of PVL leak, there's no universal agreement that was proposed that if you leak more than 5, you probably should close it. Now, perhaps more than 3, you should consider closing it as well. Large uncovered proximal lobe can be closed, or if you have a leak with thromboembolic events, this might be the conditions that you would consider closing. So I just want to conclude that per device leak is not uncommon, regardless of type and devices of closure, and can occur later after closure. Clinical significance with the new evidence suggests increased thromboembolic event even with a smaller leak, less than 5 mm. CTA might be the better or more sensitive way to detecting the leak as compared to TEE. And when it happens, I think if it's a large leak, it's probably reasonable to close it, but small, and depends on the device to use, depend on the size and anatomy. Thank you.
Thank you for the nice presentation. Is there any question or comment from the panelists or audience? Yeah. Actually, to be honest, I don't do this procedure by myself, so I could not follow. I could not follow why the leakage increase after occlusion after.
Oh, that was, I think there was a little bit new data. Normally, once we close it, before we release the device, we will make sure that the leak is acceptable. Two concepts is that normally we accept minor leaks because we believe that over time it will close by itself. And usually that happens when we follow up TE at 45 days. But the new data suggests that the leak can also increase, even though the initial perfect deployment, no leak at all, it can happen afterwards. And from the data I reviewed, it could be related to the LA left atrial appendage remodeling. It can get bigger if they have, especially if they have chronic AFib or long-standing AFib, or it could be the device itself. You know, you never know. It might have a minor migration, so it might not in a good spot. Also, if you undersize the device, even though it's good enough to prevent it from dislodge, but it doesn't seal properly. When we do this device, we always measure the left atrial pressure to make sure that the appendage is a proper size, but you never know if the patient in heart failure, the appendage can get a little bigger. And so there's so many other things that may make the interaction between the device and the appendage change over time. And what interesting is that with the late PDL, you know, it had shown in at least the data that it had associated with increased embolization. Yeah.
Thank you. Any other question or comment?
I saw Dr. Support.
Yeah.
Yeah.
Yes,
Dr.
please.
Zot from Thailand. Dr. Man, do you recommend for the follow-up imaging, which one, TEE or CT scan is better?
Yeah, from the review, CT is much more sensitive at detecting PDL and also find out the mechanism of the PDL. I think I haven't been followed up regularly. In my practice, especially if we have patient in registry or trials, we had TE at 45 days to see if the PDL is gone, and then I don't really do it again unless the patient had a stroke, in which we will do a TE looking for more or less a device clot or thrombose on the device or the leak. But now I think with this new data, it make me wonder that maybe we should do a surveillance CT at 1 year and see if that's if there's any leak at all in probably in most cases.
I think the problem is when we use the CT scan, it maybe is too sensitive. You see the some intra-device leak, and after that, what do you want to do? Yes.
Yeah. The intra-device or the membrane leak is tough. I don't think we can do anything about it. You know, but I think it's good to know anyway, because I'm not sure whether we're going to change management, but it probably had some more information and make further decision. Yeah.
So you still use the antiplatelet, no, not to change to OAC, is right?
No, I mean at the moment, no. I think because I think in our region, in most cases, the patient whom sent for LA occluder had pretty strong contraindication for anticoagulant or had high risk of bleeding, not a regular oral anticoagulant legible like in the States.
Thank you.
Thank you.
Thank you. Any other question or comment? So I don't know well, but can ask question. How many percentage patient atrial fibrillation was controlled after LA appendage closure?
How
Chronic atrial fibrillation should the patient atrial fibrillation should be terminated?
No. I think it's nothing to do with the atrial fibrillation. It's only to prevent a stroke.
Yeah, I know. But so PV isolation or if we can, so atrial fibrillation should be controlled.
Oh yes.
We after LA, after or before LA closure.
Maybe you answer that. You answer that better than me. I think it probably should be controlled, isn't it? Yeah.
So sinus rhythm is better. So
I think it's possible.
How many percentage patient sinus rhythm continued? So for patient after receiving LA closure.
I don't have our own data. Yeah, no, that's a good question. You mean that if we can control the if we control the AFib better, maybe we'll have a better result after LA occlusion too. That's a good thought. I'm not sure we have a data on it. But logically that is a good idea, I think. Yeah. Yeah. I'm not sure other expert had other opinion.
Okay. Any other question or comment?
So I think it's better to do IF ablation and put the device in.
Yes, of course, but of course, in some case, it is difficult to continue the complete complete sinus rhythm. So some patients have
helping both
recurrence,
ways. Yeah.
and of course, as you say, chronic atrial fibrillation patient remodeling become bad, so leakage may occur. So
Yeah,
I thought so.
Yeah.
But it is getting more difficult, I think, and complicated than we initially thought. Initially, we thought we close it properly and we'd be happy, but perhaps there's something more to it. I think that's a good point. Yeah, I got your point now, and I definitely agree with that. Yeah.
Sorry, thank you so much. And any other question or comment? Do you have any comment, Professor Wen?
Yeah.
Okay, so it is a little bit early, but now we will close this session. Thank you for wonderful presentation and discussion. So I hope we will meet together after COVID-19 pandemic. So thank you so much.
Thank you all.
Thank you all the
Thank
speakers.
you for your contribution.
Bye.
Thank you.
Thank
Bye-bye.
you. Bye-bye.
Thank you. Bye-bye.